these two blue things are called sequential compression devices. And typically they're hooked up to a motor over here that you turn off and on when you want to get the patient up. But the big picture behind this is that when patients are sedentary, they could be at risk for blood clots, especially in the lower leg. And it's called a deep vein thrombosis. And so the compression garments help to reduce that risk. So what you would do is typically this would be hooked up to a motor. You would turn the motor off, and then it would be turned off, and then you just take off the SCDs, and then you would be able to then start transferring them and working with them. And then when you're done, you would put them back. Joseph, do you want to put one back? Thank you. Perfect. So once you're done with therapy, you put it back, you would then put the motor back on, and then the device would be on again. Another thing I'm going to show you is called a PRAFO, which is a pressure relief ankle foot orthosis. And what happens is if a person is sedentary, they might get pressure sores on the heel. Also, when they're getting ready to walk, they may have a thing called foot drop, because the foot drop is just from being sedentary, their ankle just plantar flex just because it goes into gravity. So to help the pressure relief of the ankle as well as eliminating this idea of foot drop, we will put on this PRAFO. So it just fits in with the heel. Make sure, and we don't want the foot to be everted or inverted. We want it pretty neutral. We want the foot here at 90 degrees. And then you will leave them in this for good positioning and relief of pressure sores. So another thing we're going to talk about is sternal precautions. So let's say someone's had open heart surgery or some sort of where they've broken the ribs. They're going to have precautions that you're going to have to honor as a therapist. So the precautions are: don't reach arms overhead, do not reach arms out to the side, do not reach behind the back, do not lift more than 5 to 8 pounds, and do not push with your arms or pull with your arms. So that really does affect how they get out of bed and how they do ADLs. So what we would do, I don't have one with us, is that we would give them a heart pillow. And so they would hug the heart pillow when they're rolling, that way not to use their upper body to help push or pull on the bed. And the same thing is that when they would get from a sit to stand, they would use momentum, still have their heart pillow, and just do some rocking, and then not pushing up with their arms, and then stand up. So people will have to have a lot of lower body quad strength, some abdominal strength. If they don't have that, then of course you would assist them. In terms of dressing, because they can't reach overhead, we like to have them bring looser clothing. And so like put on a shirt, they might just do one arm, then bring it over their head, and then the other arm, so it's never having to reach over your head. For lower body dressing, we might do what's called a figure 4, which is if I'm sitting down like this, I'm going to do a wall squat, but pretend I'm sitting, and I bring my foot here. Do you see how it's a 4? That's a figure 4, and they would use this way to help them dress for lower body dressing. Sometimes they could use a reacher if they needed some help, as long as it's a light dressing task. Sometimes when we have a patient that we see and they're complex, and we talked about many different kinds of precautions today. The other thing is, let's say they have cracked ribs. Well, typically that has to heal on its own, but it's very, very painful. So if it's one-sided, then you would want to roll to the other side. If it's both sides, then you may want to just lift the head of bed so they're sitting up, and then you're helping them kind of just move from a semi-sitting position to edge of bed. Also, when you have some fractures, you might have what we call upper body weight-bearing precautions, which could mean don't put any weight bearing onto your arms. It might mean you can't lift anything with 5 to 8 pounds heavy. You can't lift anything heavier than 5 to 8 pounds, and you have limited range of motion. Now, when you have a rib fracture, You may have weight-bearing precautions, but ask the doctor if they still have available range of motion. Then you can still do ADLs, but not weight-bearing. And I think some other fractures you might have is the pelvis. You can have a pelvis fracture. And for that, they're going to give you lower body weight-bearing precautions. And what that looks like is it could either be toe touch, which only your toe can touch. It could be non-weight-bearing, which nothing is on there. And then you can have percentages of weight-bearing onto that leg. And you would practice what that feels like, these different types of weight-bearing precautions. Our patients, let's say even if they're a neurological patient, they've had a motor vehicle accident, they've had a brain injury or so forth, they can have other problems with that, like a humerus fracture, a pelvic fracture. They could also have surgeries, shoulder issues, and so we just have to be able to work around that when we are transferring and teaching them their simple activity of daily living. We're going to talk a little bit about positioning, and this is for a patient with hemiplegia. So we're going to just, for today, pretend that it's his right side that's affected. So we're going to talk about if you want to keep the patient in supine, how would you position from their head all the way down to their lower body. So the first thing is that you'd like to have their head and neck in neutral, but with a little bit of slight flexion. So this is pretty good. In terms of their involved side, we don't have pillows today, unfortunately, but I'll just talk you through it. So we want to support the scapula and as well as the arm. So what we want with the scapula is if we had a pillow to put, and he's very heavy, and this is a little bit big, but the idea is that we want that scapula to be in a little bit of protraction. So basically, if I was to lay down, I want my scapula protracted like this. And then we would like to also have the arm a bit, and let's say this pillow was moved down here, also abducted, which is away from your shoulder, externally rotated, and then you could also have the elbow extended or flexed. The reason we want that in the position is because we want to be able to have full range of motion, and if we were to internally rotate, that really limits the range of motion. Placing an external rotation gives us more room for shoulder movement, and then as well as abduction. So I'm supported under the scapula to get some protraction. I'm also under the arm, maybe elevated, especially if it's endemitous. Endemitous means that there's edema because they haven't been using their arm to kind of lift it up towards the lymphatic system, and external rotation as well as elbow extension, maybe some slight flexion. Sometimes if there is any kind of tone, we may do a towel roll to keep this straight, and so we just have a towel and take masking tape or something, what's that yellow tape? Is that masking tape? Yeah, masking tape to then tie it. And then in terms of the wrist, you want the wrist in neutral, and then we like to have the fingers open. So for the lower body, we also like to get some way off that hip. So we might put a little bit here under the lower leg. And then of course we don't want the heel touching, and so we might put a little towel roll here so that there's no pressure on that heel. This is a little bit high, but at least you understand that we're having the hip kind of a little bit forward. And then a little bit knee bent, and then putting something underneath the ankle to have relief of pressure. The reason that we're so particular about the involved side is that positioning is very important on this because he's not able to move it. This is a little bit more difficult with Hal because he's not very flexible, but also with the hemiplegia, you can also have them lay sideline on their unaffected side. So we're going to just now pretend that his affected side is his left, and we're going to have him lay on his unaffected side. So it's a little bit difficult because he's not very movable, but of course you would always have this arm forward like this, protracted, and below him. You don't want to be stacked on your shoulder because that can cut circulation, so make sure that you advance the arm forward so it's protracted. Still, we want the head support on the pillow, neutral, slightly flexed. We probably would put some pillow rolls behind here to keep him on his left side, and then in terms of his lower extremity, we can keep his hips neutral, and then we'd have this involved side kind of bent, and you'd have a pillow here, which is kind of hard to show. Can you straighten out that lower leg? Like that, and have a pillow between his legs. And then he might stay here for a little bit of time before he rolls back onto his back again. You could also, for comfort, put a pillow here for him to then, of course, lay his hand on as support, right here. I'm not going to redo this again, but it's the same positioning on the affected side. And what is nice about also positioning them on the affected side is it puts proprioceptive input, which means that the muscles in the joints are getting the input by the weight bearing. They're putting having more attention to that side. So we like to also place them on their affected side, and the positioning would be the same, where you'd have the head and neck, hopefully neutral, still protract that involved side shoulder, have external rotation, abduction of the shoulder, elbow extended, wrists in neutral, digits open, and then the same thing, hips in neutral, and you'd also, at this time, you'd have the uninvolved leg bent and the involved leg straight underneath with a pillow in between.